You mentioned surgery. I was going to ask you about that. Does surgery come into this play at some point, possibly?
It does. I mean, it really depends on what you find in your initial workup. So there are certain anatomical factors that can lead to infertility, and those are related either to the tubes or to the uterus itself. So things like fibroids, polyps that are very common can cause infertility, and blocking of the tubes can cause infertility. So those are things that we can treat surgically, and sometimes depending, I factor the patient's age and other factors into it, whether you would proceed with a surgical procedure or straight to infertility treatment.
How long or rather how many times can someone take part in this? If it's not successful the first or second times, I'm sure you've heard it too, that some people have tried 2 or 3 or 4 times to get pregnant and it doesn't work.
Right.
Can you keep trying that? Is that a safe thing to do, or is there a time when you finally have to realize it's not going to happen?
I think you have to sort of find a delicate balance. It is safe to continue trying, but you also have to help the patient in making the decision, when is it not worth trying anymore. And with fertility treatment, I think the thing to keep in mind is that it's not a treatment in that you find the diagnosis and you treat. It's basically an odds-upping type of treatment, where each time you use one treatment, whether it be Clomid or a surgical procedure or in vitro fertilization, you're increasing the patient's chances of becoming pregnancy, but you're never giving them a 100% chance. And so even with IVF, for example, in a young 35-year-old patient, the overall success rate is somewhere between about 50 and 60% per IVF try. So still, 40% of those trying are not going to get pregnant in that first cycle. So it's very reasonable to try 2 or 3 cycles, and sometimes even more than that, depending on what the other factors are, what the age factor is, what you ultimately feel like the prognosis is. Because again, you're looking at just statistical chances, and that if you're just not falling into that 50% who get pregnant, it's worth retrying.
Now, the embryology lab at Greenwich Hospital is obviously cutting edge right now. How do you see this in the next 5 years or so, to put on the crystal ball, if you will, because there's so much from just listening to you today that is to me, and I'm sure to others, mind-boggling, because you don't, if you're not going through it, you don't know what's out there, what's available, what the kind of work that you and your colleagues are doing at Greenwich Hospital and elsewhere.
I think that, I mean, the fertility world in itself is changing extremely rapidly. I think some of the things that are very exciting and that we will incorporate into the Greenwich lab as we also get bigger are things like PGD, which is pre-implantation genetic diagnosis. So this is a procedure that we basically use for couples who either have an affected child or know that they carry the gene for a disease like cystic fibrosis, for example. And we can actually now biopsy the embryos that we create through in vitro fertilization prior to putting them back into the the woman, which is really amazing. It gives you just, instead of having to wait for an amniocentesis or a CVS and then terminating a potentially affected pregnancy, you can just decide ahead of time to replace embryos that have already been biopsied and are normal. And so we've been doing this for years. It's not a new technology, but the technology behind it is changing, that now we're able to test so many more genes and identify so many more genes, as well as testing for chromosomes for common miscarriages. So because age factors a great deal into infertility, one of the factors behind age is just genetics and chromosomal abnormalities that become more common as you age. And so testing for things like Down syndrome, trisomy 18, we can now do that and do it pretty successfully. And so I think that's going to expand as well in the next several years.
That's just simply amazing to listen to you and to find out what's happening here at the center. How many people do you treat? Is there a number out there? You said more people are coming in for this help, for this assistance that you can find out about and deliver. Is that growing since you've been here?
I think that we go through stages. I think actually one of the phenomena that we have seen in the last year is that with the huge change in economy, I think many fertility practices were concerned that maybe couples would not prioritize this, because it is still a big monetary commitment because some insurances don't cover it. But one of the trends we've seen in the last year with the economy is that rather than that, women and families are actually focusing more on family building than they are on careers. And so we actually saw an increase in the number of patients coming in the last year. So things like that vary. But I think one of the big factors, and with the opening of our new lab, we also significantly increased the amount of managed care plans that we accept. And so that changes things dramatically as well. And I think that as people become more and more aware and medical insurances start to realize more that fertility is a medical diagnosis, infertility, that the people seeking treatment will also increase, the number of people.
Now, when eggs are frozen, how long is this process all right with? In other words, how long can that be? And then do you have to help the person along? Is it their work ethics, their age, whatever, that they shouldn't keep that egg for implantation too long? I don't know if I'm asking that question correctly, but
Sure.
I want to know how long this process can be.
It seems really like the important factor is the freezing process. Once it's frozen, it seems that the time it's frozen does not matter. And so when we gather that data, mostly from all of our experience with embryo freezing, that embryos can be frozen for years and years and still be viable when they're thawed. So it really depends more on the actual freezing procedure than on the length of time that the egg is frozen. And then as far as when women should be coming back to get these eggs and use these eggs, it's not clear, but we sort of extrapolate from what we do with donor egg right now, where donor egg is a procedure where if women are unable to use their own eggs, they can use the eggs of a donor, a young, healthy donor. And we typically tell women that we think that that's safe up until about the age of 50. And so while there's no real clear cutoff, a woman's endometrium, or the uterus that's going to accept the implantation, clearly functions well over 40 and still is able to accept an egg, and we can maintain very high pregnancy rates in women up until the age of 50 based on the age of the egg. So it's difficult to say. There's a lot of ethical decisions to come into play there as well, is how old do you want to be when your child is 10, and do you want to be 60 at that point? So you have to really counsel patients on not just the medical ability to carry a pregnancy, but what that will mean for offspring and family planning.
Again, a delicate balance.
Exactly.
There with that. Read about the embryologist responsible for the preparation and fertilization of sperm and eggs. Fertilization of it. What's that mean?
Basically what we do with in vitro fertilization is we take the eggs out of the woman. So this is what we do in the laboratory at Greenwich Hospital. It's an outpatient procedure. The woman comes in, we, through a process called egg retrieval, take the eggs out of the follicles and they go into our embryology lab. At the same time, the partner or the male is coming in and giving a semen sample, and we then take the sperm and we basically combine the egg and the sperm in a dish, and then fertilization happens still naturally. The process happens like it would happen in your fallopian tube, and we use culture media similar to what is in your fallopian tube at the time that fertilization would be happening in your body. So we use that in the lab and allow that to happen. In patients who have a very significant male factor who that fertilization might not happen for, we can use a process called ICSI, where we actually identify one sperm and under a microscope inject it directly into an egg.
You have fascinated me for 30 minutes, I'll tell you that, and I think everybody else out there too. Our time's run out, but I hope we'll talk again, and thank you so much, Dr. Fino. It's been enlightening.
Thank you very much. Thank you for having me.
It was a real pleasure. Thank you so much for joining us here at Greenwich Hospital, bringing us to your health. Until next time, I'm Jim Thomas.